just record here. Okay, so I think we are good to go. I think we're good to go now. So it's 5, and so it's time for us to commence. Just a minute. Yeah. Okay.
Yeah. Is there something like this?
So we're behind our time by 2 minutes. Sorry, are we still recording? Yes, it's still recording. So thank you for all of you that joined early. I believe it's been a very busy day for all of us. However, distinguished policies, partners, health or researchers, students, and everyone, good day and a very, very warm welcome to this highly anticipated June edition of Cheap Talk Africa. So whether you're joining us live across the continent or tuning in globally, we are thrilled to have you with us. As many of you know, the dialogue we began middle of last year, and we started it to confront pressing public health issues within the premise of the CHEAP mission. For those of you that are just joining us newly, our initiative is named CHEAP, C-H-E-A-P, CHEAP, because we firmly believe in the old saying, prevention is cheap, cheaper than cure. This simple phrase is the foundational rule of public health, and it forms the absolute bedrock of One Health approach. CHEAP stands for C, community, H, health, E, enhancement, A, aid, P, project. Community health and enhancement aid project. And our vision is simple: resilient, healthy communities across Africa. To achieve this, our mission focuses on promoting One Health, empowering local actors, and tackling zoonosis, poverty, and climate threats. CHEAP is an initiative of the War Against Rabies Foundation, WARF. We are a One Health charitable organization registered in Nigeria since 2017, and we've been working towards a rabies-free Africa. Now, through this Cheap Talk Africa platform today, we've been hosting highly engaging conversations with Africa's most knowledgeable scientists and policymakers. And to date, we have brought together top experts and attendees from Namibia, Tanzania, Ghana, Sierra Leone, Cameroon, Nigeria, and our audience. We have global audience, and it continues to grow rapidly every single month. We are incredibly proud that our platform actively includes and empowers both undergraduate and postgraduate students as our vital moderators and audience members. So once again, good evening, everyone. Welcome to this June edition of Cheap Talk Africa. Today, we are tackling a monumental theme, from outbreaks to countermeasures, driving local innovation and to safeguard Africa's health and health security and sovereign agenda. Very, very important theme. These conversations are calls to heightened vigilance and integrated action. To truly break the cycles of disease transmission, we cannot work in isolation. We must bridge the gap between human medicine, veterinary medicine, and environmental health. We keep repeating this so that it's, sticks to our brains that this is very important, because that is the true spirit of the One Health approach. To steer this powerful conversation, I am joined by an incredible moderating team that perfectly embodies the intersection. So, Africa CDC and the War Against Rabies Foundation student member. Okay, so first, please join me to welcome Oluwatoyosi Olabande. Oluwatoyosi Olabande is a public health specialist, social behavioral science researcher, and cross-border regional focal point for the Africa CDC. Co-moderating alongside her is Tonga Augustine, representing the frontline energy, really energetic, of the War Against Rabies Foundation, and a brilliant future leader currently in veterinary school. Tonga brings that indispensable frontline student perspective that makes this platform so unique. Toyosi, Tonga, it is wonderful to have you both steering this ship today. Toyosi, I am going to floor to you to formally introduce our esteemed keynote speaker, Dr. Mosoka Fallah, and kick off the session. So the floor is yours, Toyosi. Thank you very much.
Please confirm if you can hear me. Good evening, everyone. Thank you very much, Professor Grace, for that wonderful introduction about CHIP, especially for our for the first time audience today. So today we have, like she rightly said, we have the pleasure of bringing to you Dr. Mosoka P. Fallah, and I'd like to call the media to please kindly play the bio video so that everybody can be carried along on this exemplary icon we have in Africa. Over to you, media.
Welcome to the June edition of CHIP Talk Africa. This month, we tackle a monumental theme, from outbreaks to countermeasures, driving local innovation to safeguard Africa's health security and sovereignty agenda. To lead this critical conversation, we are privileged to feature an icon of global health, Dr. Mosoka P. Fallah. Dr. Fallah is a world-renowned Liberian epidemiologist and immunologist who currently serves as the Acting Director of Science and Innovation at the Africa CDC. In this role, he is at the forefront of transforming the continent's health security, building resilient clinical trial networks, and championing localized medical manufacturing. His legacy of crisis leadership is globally recognized. In 2014, Dr. Fallah was named a Time Magazine Person of the Year as an Ebola fighter. During the devastating West African outbreak, he served as the head of case detection and contact tracing for Liberia's Montserrado County, developing community-driven tracking systems that saves countless lives and reshape modern epidemic responses. Dr. Fallah consistently bridges frontline humanitarianism with top-tier global scholarship. He is the founder and CEO of Refuge Place International, an NGO dedicated to cutting maternal and infant mortality rates in marginalized urban slums. Simultaneously, he helps train the next generation of public health leaders as a lecturer in global health and social medicine at Harvard Medical School. His phenomenal academic path includes a PhD in microbiology and immunology from the University of Kentucky, alongside a Master of Public Health from the Harvard T.H. Chan School of Public Health. He brings this unrivaled wealth of expertise to our studio to discuss how Africa can achieve self-reliance and safeguard its health sovereignty. It is an absolute honor to welcome Dr. Fallah to CHIP Talk Africa, the monthly dialogue of the Community Health Enhancement Aid Project, an initiative of the War Against Rabies Foundation.
Thank you so much, media, for that brief bio on Dr. Mosoka Fallah, and also is the director for the Science and Innovation Directorate under the Africa CDC, and also the research pillar lead under the joint IMST with WHO. So it's our pleasure to have Dr. Fallah here to give us his perspective on leading local innovation from outbreaks to countermeasures. So over to you, Dr. Fallah, for your address. Thank you for your speech.
Thanks, everyone. Thanks, Good Grace. Thanks to Toyosi. You might hear some noise in the back. This is some of our work. Flying up tonight to DRC for the ongoing Olabande outbreak. So I'm in between the airport for background. We try to multitask and share with you some experience. My talk is broken into probably two parts. Something about the background, the increasing outbreak we have in Africa, some of the clinical trials we are running, and then some of our efforts as Africa CDC to address the issue of medical countermeasure. I will be sure to wait in a few minutes to sit. I'm trying to go through cost control. Kindly forgive me for the background in the airport. So maybe we'll go to the slides. Hello, can you hear me?
Yes, we can hear you, sir. Media, please, can you put up the first slide?
Can hear you, sir.
Kindly put up my slide. I'm so sorry, I didn't want to let you down because I got this emergency call to rush to the DRC, and I thought we should do it together. So kindly forgive me as you might hear some small interruption. Give me like 5 minutes, I'll be ready.
All right, this is noted, sir. So you have your slide here. So Luwani, kindly put it on presentation mode, slideshow. All right, thank you very much. So Dr. Fallah, when you're ready, your slides are up. Dr. Fallah, if you're speaking, you're on mute.
I was just speaking, I was crossing the checkpoint, so sorry. Forgive me, I'm trying to get, yeah.
All right, so just Dr. Fallah.
I just settling down now. Okay.
Right.
So, colleagues, we are going to discuss where we are and what sort of countermeasures we are finding solutions within our Africa Health Sovereignty and Security Agenda. Kindly forgive me for any interruption. I try my best to see how I can make it in time. Next slide. Can you move to the next slide, if possible? So what I try to show in the next slide is that we see multiple outbreaks on the continent. If you go to the previous slide, you see there are multiple outbreaks on the continent, and the reality is shown. You can see the different outbreaks globally, and some of the outbreaks they are occurring with frequency. In the last 3 years, for instance, we had to respond to Ebola Sudan, Marburg, and the Ebola Zaire at the same time. Next slide. We think climate change, increased urbanization is causing these multiple outbreaks. I will keep this slide up for a few minutes so you can see the reality of what we are going through in terms of the ongoing outbreak, Olabande outbreak in the DRC. Next slide, please. Next, please. Next slide, Toyosi. And we know that these are the factors that are causing these multiple and frequent outbreaks: climate change, urbanization. And what we've done as Africa CDC is to take all of these pathogens and to rank them into areas based on the mortality, mobility, and whether we have new drugs or treatment. It is sad to note that in many of these diseases, Africa has no medical countermeasure. Next slide. So in the next couple of slides, I will try to convince you in a couple of studies that we are leading in terms of, the airport is not say forgive me, yeah, in terms of addressing these diseases. I'm so sorry with the background. So we start with Mpox. As you may all be aware, there is no treatment for Mpox. And what is unique about all the diseases that affect Africa is that diseases, now this is the global spread of Mpox based on a different clade. If you watch carefully, if you look at clade 1A, clade 1B, the green and blue, and then clade 2A and B, you find out that it is in Central Africa, it is in, and then you also see you all know about the clade 2B that is in West Africa. Oh, okay, thank you. The key I want you to note is that Mpox has been around for 50 years in Africa. We have not had any therapeutics. Next slide. As African scientists, I want you to note that. Next slide, please. We don't have any antiviral for that. The first study was using tecovirimat to look at Mpox, and they showed that it was not effective. Let's go slowly. Go back to the previous slide to see the previous slide. So we showed that it was not effective, and so Africa CDC decided to partner with a French organization because there was a need for treatment to be designed and developed on the continent. And next slide. So we developed a randomized control trial. Next slide to see. Next slide to see. We developed a randomized, no, to see, you're going too fast. Go back to the previous slide. Okay, start right there. So we developed a platform adaptive, double-blind, randomized, multi-center clinical trials to see if we could have a new drug called pranzanefovir, an antiviral that showed the signaling pathway that is used in host versus graft diseases. And so based on that, it's being used for HIV children. So we said, let's see, based on the signaling pathway, if we can be able to use it for the treatment in a controlled trial for patients. So we sent protocol with multiple teams from around the world to be conducted in African countries. Next slide. So watch this, carefully watch this graph. After extensive consultation with multiple clinical trial group, regulatory group, including the European Medicine Agency and African Medicine Agency, it was agreed that we go ahead and randomize participants to receive the drug. There will be two critical milestones. Listen carefully. The first milestone, if we recruit 50 patients, we check for the safety. So around 6 months ago, we were able to recruit the 50 patients. After we recruit the 50 patients, we are now moving to the next stage of the trial. The initial 50 patients were recruited in the DRC. However, later on, we had an outbreak of Mpox in Madagascar. We went ahead and started the trial in about 3 weeks. We are happy to announce that we have recruited up to 93 participants. In the coming weeks, we are going to recruit 100 patients and we'll do the interim analysis to show if the drug is efficacious. If we pick any strong signal, we'll then expand to other countries, including Nigeria, Sierra Leone, to expand this trial. And what will be unique is that it will be a trial launched by Africa to find therapeutics for a disease that plagues the continent. Next slide. So as I explained to you already, we are going to recruit 100 patients, analyze and go to 200 and create multiple steps and sites across the continent to demonstrate that African can be able to work with partners to launch a clinical trial using local investigators. Next slide. I will not spend much time because Toyosi is with you. The message is that during the Mpox, we had a big ambition. We wanted to launch a multi-country social behavior science research to look at people health-seeking behavior towards Mpox and towards the vaccine. The Homo servant Toyosi was working to lead this trial. It was unique in a couple of ways. All of the investigators were African in 10 African countries, including Nigeria, Sierra Leone. And we are happy to announce that we ran a multi-country trial. We recruited 37,000, we were able to interview 37,000 participants. Next slide. Next slide, please. So this is the background, as I said to you. As of the end of the study, we recruited 37,000 participants, both qualitative and quantitative research, one of the largest database on social behavior science that was successfully done by Africa CDC and African countries. Next slide, just to show you the countries. Because of time, we now have to go through them. Next slide. So these were the countries. You have these countries. Next slide. Next slide. Okay, so these are the 10 countries that we did the study in. African PR, working with Africa CDC to demonstrate this study. So what I tried to show you in terms of Mpox is that we did a clinical trial and we did a social behavior study. I will now shift gear to what we are doing now with the current Ebola outbreak. Next slide. So let's look at some of the research we are doing. I will leave this slide because of time. I wouldn't want to go. Next slide, please. So we realized that whenever there is an outbreak, there is a need for rapid generation of evidences to see how the outbreak is operating. As a matter of fact, Africa CDC has developed a continental framework for operational research during outbreak. So right now, as I speak to you, we are finalizing we have gotten the protocol approval. A team will be deployed in Bunia, DRC, to generate evidences to see the weaknesses and the lapses and use that to inform the response. So we have a strong research operational team that move very quickly when there is an outbreak to generate evidence to inform how the outbreak. We did that with the malaria in Namibia, Lesotho, and Zimbabwe, and we're able to show to the ministries of health the factors that were driving the rebound of malaria in countries that were approaching elimination. Next slide. I will leave this slide where you take your time to look at them. Next. We also are going into One Health research. We want to understand the animal reservoir, the spill oil, and it's going to be, as I know this group is a One Health group, we'll be happy to elicit idea from you, but we have a protocol we have developed. We are waiting for approval to go ahead to look at the intersection between the animal, human, and the environment to some of the work we'll be doing will be getting bush meat in the market and doing some metagenomic analysis to understand what is consistently driving repeated Ebola outbreaks in the DRC. Next slide. Next slide, please. Again, we are using the same model we use for Mpox to go ahead now and look at social behavior study driving the people response, their help-seeking behavior, their response to treatment in DRC, in Uganda, and we'll look at a little bit of cross-border movement. We want to develop gender-sensitive evidences to look at help-seeking behavior. As you can see, our research for medical countermeasure does not only include vaccines and therapeutics, but we also try to look at epidemiological study and 1F study. Next slide. Next slide, Toyosi. Next slide. Next slide, please. We have a treatment. We are going to begin the treatment protocol this week. As a matter of fact, that's the reason why I'm flying to the DRC. As you may be aware, the current strain of Ebola, the Ebola Budembuayo, does not have any treatment. But we have gotten some evidences to repurpose some drugs, the monoclonal antibodies and remdesivir. We are going to do a randomized control trial with about 80 to 100 patients to be able to see if the treatment, these new antibodies are safe and have efficacy. We are working with WHO, Oxford, and ANRS to launch this study, multi-partner study to look at treatment in the current outbreak. Next slide. The next most important slide, and it's very important because we do not have a vaccine right now for Ebola Bundi. There is no vaccine. So our best option now is a post-exposure prophylaxis. Gilead Sciences in the US have demonstrated some evidences that they have an oral form of remdesivir, a tablet, that the tablet can be used to prevent people from developing symptoms. We are going to recruit 1,200 high-risk contacts, administer the tablet to them for 10 days, and observe if we can prevent them from developing symptoms. If we succeed with this trial and get signal of efficacy, we're now expanding for all contacts. In the absence of a vaccine, using a prophylaxis is the most optimal way we go. So the partner trial, which is the treatment trial, and the post-exposure prophylaxis, which will be launched next week. By the time we recruit 600 of the 1,200 patient participants, we'll do an interim analysis and be able to tell if it worked and then move it quickly into the outbreak. Next slide. Next slide. Next slide. Okay. Now, this contains a few slides. I'm not going to go over the slides. I'm going to summarize, and I will leave you with the slides to look at it later on. Take your time. What is the bridge study? This is a collaboration Africa DC and IAVI. What we have demonstrated, what have been demonstrated in animal model, is that if you give the Ebola Zaire vaccine, there is no cross protection for Ebola Zaire or Ebola Sudan. But early non-human primate studies demonstrated that if you prime with Ebola Zaire, an animal with Ebola Zaire, and you later boost with Ebola Sudan, and you challenge them with Ebola Bundi, you have 100% protection. So now we've developed this protocol. We are going to launch this study in Uganda and Rwanda, where we have some participants who were previously vaccinated with Ebola Zaire and J&J. We are going to vaccinate them with Zaire, and then prime them with Zaire, and then boost them with Ebola Sudan vaccine, and then do some immunological analysis, like neutralization assay, total antibodies, and functional acid. Our goal is that if we can successfully demonstrate that the current vaccine, which cannot give cross protection if they are used alone, if we use them in combination, they can do cross protection. It will enable us to move faster. Why is this study important? So you can move to the next slide. This study is important because the number of vaccines we have, we have 3 vaccines we are manufacturing. When I say we in the partnership with CEPI, there is the mRNA vaccine, there's the Ox vaccine, and the VSV. But none of these vaccines will be available until around December. That's why we are trying to quickly work on the cross-protection cohort study in Uganda and Rwanda. Once we generate the evidences, we can then quickly move to DRC. Next slide. Next slide. We will not go through this. I'll leave the slide with you. Yeah. Next slide. Can you quickly move the slide? So this is the design of the study. I will leave the slide with you. Those of you who are interested, you can look at the study and see how we are designing the study for Uganda and Rwanda, and use the evidences to go. If we see any signal of immunogenicity, we then move to DRC. Next slide. Next. Just go forward. And Toyosi, you can go ahead. Move ahead. Next. Toyosi, can you move a little bit faster? Can you go ahead? Okay, we're discussing the impact of this study, the strategic value. I know this presentation is about, okay. So I've just shown you some of the way we work on developing medical countermeasures during outbreak. But you see that we are developing these countermeasures during outbreak. This is not the ideal. The ideal is for us to work before the next outbreak. So in the next few slides, I will show you some of the things we are doing to prepare the continent and to invite some of you to join us in some of the activities we are doing. Next slide. Can we move the slide a little bit fast? Yes. So what you see showing there, I want to take my time to explain. On the left, we've been trying to identify diseases that affect the different parts of Africa. We have gone to around 40 countries, including Nigeria, Ghana. In West Africa, we've done all the countries in West Africa with the exception of Benin, where we sit with the countries and ask them what are their diseases of priorities. And we review that. On the upper right-hand side, we've gone into countries to identify all of the research centers, what is the research capacity they have. And now what we are doing is that we're building a big database for all African scientists to say, if you want to do a research, if you don't have the capacity, your neighbors in this country have the capacity. Next slide. Next slide, please. Oh, next slide, colleagues. Okay. Now you can see, for example, if you look at here, and you look at the upper right, Lassa fever in West Africa has been found as the most important disease. Now we showed that we're identifying the infrastructure for African scientists. We are bringing them together. The other thing we are really pushing is to divide between basic research and translational research. African scientists have not done a great job in translating research to the needs of the country. That's why we don't get support from our local government. So we are working on that system to take basic research and move them to translational research. How are we doing that? Next slide. So essentially, we are taking this concept with different diseases, and we are looking at natural therapeutics. We have a whole group on natural therapeutics, African scientists who are selling our traditional medicine. We are also working with a group of scientists in therapeutic repurposing. In fact, all the drugs we are using for Ebola and what we use for Mpox were therapeutic repurposing. What we have discovered is that if we repurpose a drug, it's shorter. It takes around 4 to 5 years to do this, the R&D. It costs 300 million compared to 3 billion if we went through the traditional pathway. So we are doing that, to move this drug quickly for African. Next slide. A good example is on the natural therapeutics. We are working with scientists from the Senegal who have identified a plant that could treat an HIV/AIDS, and now we're trying to look at that drug and move it towards treatment of mpox developed on the continent. What I want you to watch at the bottom is that all of the research that are needed for this drug to get ready for clinical trials, they are done on centers in Africa. We are not taking it to Europe, but in order for us to do this, we had to bring all of the different countries and their research capacity together. Now, let's go ahead to the next slide so you can see what I'm saying. I want to come to a practical application in Nigeria. Next slide. You see right now, we are working across South Africa. If you look at the last slide, they stop right there. We are working on a plant-based product that we are moving across the continent. So we are using each site on the continent that have the capacity to do a study so that any African scientists that have developed a molecule, you don't have to be strangulated because you don't have the capacity. We are going to give you the ecosystem that you can move your studies through. Next slide. Can you move? All right, fine. So what I'm trying to show here is basically African countries, including Nigeria, have shown that it is possible for Africa to invest in R&D. On your right is President Museveni launching an R&D plant. And on your right is the Ethiopian government. They have invested $37 million to build a research plant. So we tell people it's not impossible, it can be done. We can do research for countermeasure on the continent. Next slide, the last batch of slides I will show you. Next slide. Next slide, please. All right, this picture is very telling because this is where I met Grace. We brought together 82 African scientists under the context of developing One Health consortium to address two critical diseases. One of the diseases we are looking at are the filoviruses, the Marburg and the Ebola viruses. The second consortium is the arboviruses, your dengue, your Rift Valley fever. We met for 2 days in Addis Ababa with scientists across the continent to develop a consortium and a protocol to address this disease. So these are homegrown solutions. Next slide. Next slide, please. So you see that we develop a group of, again, very important for this talk. It is One Health in nature. We are generating evidences. We are developing new drug. That's the goal, all driven by African, working together with our African partners. So the opportunity for students to get involved on the continent with initiative is becoming very possible now. Next slide. Next slide, please. So basically, these are the different areas of research we're looking at. We're looking at filovirus ecology and genomics, human and animal exposure, ecology, climate and spillover, social and behavior determinant, climate outcome, and diagnostic vaccines and therapeutics. As you see, each of these 7 areas is a work package that requires different scientists to be able to work. And all of this is done under One Health. Our goal, we started today with filoviruses, arboviruses. We are going to move to AMR. If Grace advocates strongly and we see a need, we can move towards rabies. But our goal is to treat One Health-related diseases, bring Africans together in an ecosystem to be able to address these diseases because the diseases are happening in Africa and the African scientists have to find a solution. The time is now. We have shown that our continent is at risk of increasing outbreak, but we have shown that we have the capability to design and conduct studies all in the context of One Health. So for the sake of time, I will stop here and thank you all for the opportunity you've given me. And I did not underestimate this opportunity. That's why, in spite of the fact that I'm traveling, I still thought to take the time and share with you so you are aware of what we are doing as a continental organization and to realize that this is your organization. We want you to plug in. We want to build more relationship. I will leave this slide here because of time, and then they can calculate the slide so you see what we're doing across the continent. Thanks to Grace and the organizer, the chief group, for the opportunity they have given us. We have a working group on filovirus. We have a working group on arboviruses. We are now developing a working group on AMR. If you want to join, work with Grace, work with Toyosi, and we can have you join so you can bring your expertise to work on the different work packages. Thank you very much for the opportunity.
Thank you very much, Dr. Fallah. This has really been a masterclass presentation. Thank you for showing to us that it is no longer brain drain as usual, but we are having brain gain on the continent. So, sir, please, we just have a couple of questions to ask you before you board your flight. So, excuse me. So we know that Africa has the political will for health sovereignty, but we often face massive bottlenecks, ranging from regulatory fragmentation to raw material supply chain. Sir, from your vantage point in the Science and Innovation Directorate at Africa CDC, what is the single most critical bottleneck we must break in the next 24 to 36 months to ensure local manufacturing of countermeasures so that it becomes a reality rather than just a policy goal? As you always say, talk is cheap. Right now, we want to see it translating into action. So we want to find out, what do you think is the single most critical bottleneck we must break in the next 24 to 36 months to ensure local manufacturing of medical countermeasures? Over to you, sir.
That's a good question. Actually, we are using the Ebola Bondi to develop a framework that will accelerate local manufacturing of African products. So what we have done, we have set up a scientific committee of African scientists to review all product developed on this continent or by the diaspora that have potential efficacy towards Ebola. This will be the first time. We are also developing an adaptive protocol so that any African who has a product and think they have sufficient evidence, human, animal evidences, in vitro data, to move it, we'll move it forward. But the single most important challenge we have is funding. We are not funding our own research. For the last 2 decades, the African Union asked each member state to contribute 1% of their GDP for R&D. Only 2 countries are approaching 1%. That's Egypt and South Africa. And so what we did to find a solution to this problem, we have developed what we call the R&D investment case. I presented it in Geneva and also recently presented it in Cairo. What we have shown in the investment case is that if African governments are able to invest 1% of their GDP for R&D and 15% of that 1% go to research, in 20 years, they will be able to raise $686 billion. They will be able to create 4.56 million jobs. But someone will say 20 years is a long time. What we also demonstrated in the research is that in 4 years, if we start to invest 1% of our GDP, we'll break even in 4 years. We also demonstrated in that research that just our telecommunication were able to create 1.5 trillion investment. R&D will give investment. So now, how do we solve that problem? The way we are solving now is that we set up ambassadors to speak to various ministers of finance, minister of industry. This year, we are going to be meeting in South Africa with the South Africa Medical Research Council to bring ministers of finance and trade to convince them that R&D is not just money you throw away. It brings investment to the country. It creates jobs. That's the first thing we want to show. It also demonstrates that by investing in R&D, you are able to have medical countermeasures. So the first problem is financing. So we are starting a very big advocacy. We've done that in Geneva, and we are in multiple countries. The second thing is ethics and regulation. In a few weeks from now, we are going to be meeting in Uganda, where we are bringing AMA and Africa CDC and all our technical partners with a goal to do a tabletop exercise that will show us to be able to launch a new trial. If a new product comes, we can be able to have the study done in 10 to 15 days. Because one of the biggest frustrations researchers have in Africa is ethics and regulatory approval. So we are working on this, working closely with AMA to be able to demonstrate that we can do this in a tabletop exercise. And also in real life, we are working with WHO and other partners for this coming Ebola vaccine to demonstrate how we can do accelerated approval. So that is another issue. The third issue is the issue of supply chain and R&D supply chain and logistics. We are working with Medicine Pattern Pool and CEPI because we are going to launch the first hub and spoke model in West Africa. We have identified 16 research institutions across Nigeria, Mali, Senegal, and Ghana, and a few other countries that are advanced enough to serve as a hub. And one of the things we'll do once we launch the hub, we are going to try to pilot on research R&D supply chain, starting with mRNA to demonstrate if it works. So those are the issues that we see: funding, ethics and regulatory harmonization, and speed and supply chain. We are trying to address those, and most of those will be piloted this year in the next 6 months, and we'll be able to generate evidences and move forward. We have the goodwill and the partner support. Thank you.
Thank you very much, Dr. Fallah, for that insightful reflection and giving us hope that we are going to see something in less than 24 months. So I would like to hand over to my co-moderator, Dr. Tonga, to also ask a couple of questions before we hand over to the audience. Over to you, Dr. Tonga.
Thank you so much, my dear moderator. I don't know if you can audio me. Am I loud and audible?
Yes,
Yeah,
you are.
Okay, thank you so much. Thank you, Dr. Fallah, once again for that excellent presentation, which presents and beautifully illustrates how local innovation change the game. As veterinary student and part of the WARF team, I'm deeply aware that over 60% of the existing human infection diseases and 75% of the emerging ones originate in animals. When we talk about local innovation and countermeasures, how do we ensure that veterinary science and animal surveillance and the One Health approach are baked directly into African health sovereignty agenda rather than just treated as an afterthought?
No, that's a great question. If you saw the consortium that I just shared with you, if you look at the board, if you look at the presentation that is up, you see there's a substantial portion of that have to do with veterinary medicine. We need to reach out to more of the vet because some of the questions we are having, like the spillover, the ecology, it has to be addressed by vet. We need to bring more and more vet to join us in the different groups. And I will make a public appeal if you have vet there, because you can see all of the different research areas we have. Almost 3 of the 7 research areas, they are areas that we need veterinarians to join us to come with their innovation and their tools. One of the biggest suggestions that is coming now, we're calling universal vaccine. The theory on universal vaccine is that we want vaccines that we can use to treat both animals and humans. It will require a lot of innovation. What we can find is conserved regions that we can develop vaccines that can target both animal and human. We think into the area, maybe if we vaccinate animals, we see that in rabies. How do we protect human beings with the pandemic disease? So there's a lot of opportunity for vet to come into this group. And in all of our consortium that we're forming, we really want to reach out to the vet to join us, because most of the key questions we'll be asking on spillover dynamics, on ecology of the diseases, and we need a vet to join us and bring innovation. So we are open to vets to join us and bring them. We need to be intentional to bring the vet to join us in all of these consortia. Thank you.
Okay, thank you so much, Dr. Fallah, for that profound insight. On One Health, we have an incredibly diverse room of public health practitioners, students, and advocates tuned in today. And the chat box is amazing, buzzing with questions. We want to hear from you. And my co-moderator and senior colleague, and I will question. Please keep your question brief, please, so we can get through as many possible. So I don't know if there's any question from chat box, so that our speaker can respond to that. Thank you.
Thank you so much, my moderator, Dr. Tonga. I'm checking the chat box at the moment. I can't see any question yet, but please feel free. I can see a lot of compliments, people thanking Dr. Fallah for the great presentation. So please feel free to raise your hand, or you can even just unmute to ask your question. We have a few minutes left, and we also know Dr. Fallah is very busy. So please feel free to ask your questions. Okay, so I can see a question from in the chat box. The question is, let me quickly read that out. How can Africa leverage the high proportion of its productive age group, that is the demographic dividend, to tackle some of the health challenges facing the continent? This question is for you, Dr. Fallah.
No, that's a very good question. In fact, one of our strategic objectives, I didn't have the time to go through our 7 strategic objectives. One of them is capacity building, investing in the next generation of researchers. This year, we are launching 2 capacity building projects. One is the physician scientist program. We are going to be recruiting around 30 physicians, pharmacists. Maybe we should say vet, we can think through it, but we're going to be recruiting physician pharmacists and PhDs and do intensive 2 weeks training with professors, and then we'll put them in 2 months, we'll place them around Africa where they can become independent investigators. For too long, when we launch our research in Africa, the independent investigator are either in Europe or America. This is the first start, but we hope that this can be a long-term program, but we got some funding to start a pilot where we take a combination from every country. We take an MD, a PharmD, a PhD as a team and train them. And the reason why we're training them as a team, we want them to go back and work on a project together. The issue of silos is an issue. The next thing we're trying to do is we're trying to recruit some senior scientists to train them into mRNA. This coming September, October actually, we're having a big continental training on mRNA in Africa CDC. We are going to be inviting around 55 candidates. It's going to be an open competition. We are going to put it up, announce it. People can apply. But this is just the beginning. We think we need to invest more and more into taking young researchers and turning them into independent scientists. But this is what we have for now. Is if you look at our strategic objective, capacity building, we need to work on that more and more. And we're going to stay in touch. And the more we get more funding, the more we expand this program on training mRNA and other training. But that's what we want to do. It's an daunting task. We need to work more with universities to develop training system and program to enable them to work through this system. But we're starting this with a few universities across, even Nigeria. We're going to be partnering with Nigeria, Ghana, Senegal, Rwanda, and South Africa for the training of the first cohort of clinical investigators, clinician scientists, and we intend to expand upon it. So keep your ears open. We are going to send to countries. They will send us 6 CVs. We'll review the CV to take the best candidates and then they have 2 weeks, and then we place them for 2 months, and we pay them for the 2 months. They'll be placed in different countries to go through understanding all of the components that they can serve as independent scientists. Our long-term goal is that this investment in the initial group of people is that they will go and reproduce themselves in the countries. That's the ultimate goal. They go back home and they reproduce themselves. That one of the ultimate goals we have in this group of senior scientists. We want to train in mRNA and to become independent investigators so they can go back home and reproduce themselves. Thank you.
Okay, thank you very much, sir. Before we hand over to colleagues that have raised their hand, there's another reflection in the chat box. So this is from Adedeji Samuel Adekoke, and he's saying African countries should consult Nigeria in technology in any field because Nigeria is the giant of Africa, and Nigeria can also get better technology from USA and UK. Plagiarism is a crime. Thus, all African countries should reference Nigeria for their technology in all fields of life. So it's just a reflection. I think there's no need to.
No, if I would say, I think the way I will rephrase it, they should twin with each other because it's not only Nigeria. Trust me, if you go to South Africa and see the technology, I just came from Egypt. Egypt has the largest manufacturing plant. I see this in Tanzania. I see this in Uganda. In many of the countries that I go to work, the way I will frame it, African countries should twin and consult each other to leverage on the existing technology they have for us to accelerate instead of looking to the north. So that's how I see it. Like Nigeria will learn from other can learn from Nigeria in many other areas. Where, for example, the team is coming to Nigeria for the diagnostics R&D Nigeria leading through Codex Pharmacy. But I think we need to build an ecosystem where we learn from each other. The best and cheapest ways to learn from each other than looking to the global north. Thank you.
Okay, thank you very much, sir. So let's hand over to Ishaya, please. You can unmute and then later we'll go back to what you have on the chat box. So Ishaya Teki, please, you have the floor.
Thank you. Thank you for the presentation. And it's a very lofty idea and agenda indeed. But I want to ask, is the focus only viruses? We also have some African challenges such as Lassa fever, ASF for animals. Are there plans in the pipeline to focus on this that also require some vaccines, or the focus is that of filovirus alone? Thank you.
Gold memory. Hello, no, it's not at all. It's not only I just show you a slide. Maybe you did not pick it up on the filovirus in West Africa. We are having a current project with South Africa to develop a drug, a nanotechnology drug for Lassa fever and Rift Valley fever. We have not only filovirus, but arbovirus and AMR. So Lassa fever is a big priority to all. We have a project now with a Nigerian South African in South Africa working on that. Some of the product will be moved to University of Ibadan to test them in the Drosophila project. So there are many other diseases. If you look at the slide, you take your time and review the slide, you'll be able to see that.
Oh, thank you very much. Thank you.
Okay, thank you very much, Dr. Fallah. Tonga, please, can you read some of the reflections we have in the chat box? Over to you.
I'm at the counter now, so you have to give me a few minutes. They said there's pressing question.
Okay, so there's a question here. I think maybe Tonga is unable to speak, maybe network. So the question is, are ecologists an integral part of your research group and capacity strengthening plans? Do you have...
Except there's press, I want to thank you. I'm not trying to get my ticket. I'm a gold member. You found my name? So thank you so much for everything. We can have subsequent discussion at your free time.
All right, thank you very much, Dr. Fallah. I would like to hand over to Prof. Yes, so I think I can, so for some of the questions, I can answer them because I can see a question on if our activities cover Cameroon. Yes, because this is Africa CDC. We work for the 55 member states of African Union. So we always say your Africa CDC, our Africa CDC. We are funded by the African Union. So our research work covers Cameroon. So like we said, what we are doing right now is we are doing research prioritization, what each country is prioritizing, and then we are also grouping it at the regional levels to ensure that we are able to make good use of the limited resources that we have. So that's what the father was talking about, the twinning, that it's not just you, we are looking at building, having centers of excellence, research excellence, so that from there we can have what is like of priority in that region, and come together as scientists to address those challenges. So that's the reflection I have on if our activities also cover Cameroon. Yes, it does. Thank you. So Dr. Fallah had to, I think he's passing through immigration at the moment and he's unable to take more questions, but we definitely send these questions across to him so that he can also have an idea of the reflection from the room of what people are thinking about and what they are concerned with or what they need clarification on. So with that, I'd like to hand over to my co-moderator, Dr. Tonga. Do you have any last words from you before we hand over to Professor Gray?
Okay, thank you so much, my co-moderator. I think as we close today, my biggest takeaway in the African health sovereignty cannot be built in silos. True security lies at the intersection when we innovate locally and we must think holistically, integrating human medicine, veterinary, vigilance, and environmental health under a resilient One Health banner. True prevention happens at the community level, on the ground, before the front line is breached. I want to extend my deep appreciation to our keynote speaker in absentia, Dr. Fallah, for his invaluable time and veterinary insight today. And thank you to the African CDC team, the entire WARF network, and most importantly, to every single participant who joined us and brought their voice to this vital conversation. The momentum does not stop here. Let's carry these action points to our respective fields. With that, I will hand control back over to our host, Professor Grace. Thank you all.
Wow, what an absolute phenomenal, deeply enriching session. So this is Dr. Mosoka in transit. You can imagine if he was stable in one place, the wealth of knowledge that you would have drank from. Because already with what we already have, we have a lot to go back home and think. The opportunities that have been opened up to us, so enormous. So we have come to the end of the June edition of Chip Talk Africa, and my heart is incredibly full. So we set out today to discuss how we can drive local innovation to safeguard Africa's health, security, and the sovereignty agenda. And we have we've received nothing short of a masterclass meeting presentation from Dr. Fallah. First, I want to extend our deepest and most profound gratitude to our esteemed guests, Dr. Mosoka P. Fallah, who is the Acting Director of Science and Innovation, Africa CDC. Dr. Fallah, thank you once again for your time, your unmatched expertise. I know he's not presently here, but he's going to see it someday when he watches this YouTube. Most importantly, your lifelong dedication to the health security and self-reliance of our continent. Once upon a time, he was just fighting Ebola quietly in the communities in Liberia. He didn't even know somebody was going to see him and pick him and give him the Times Magazine award, a huge award in 2014. Your insight today reminds us that the road to sovereignty requires bold local innovation, integrated networks, and relentless vigilance and hard work. I also want to give a massive round of applause to our incredible moderating team. I'm looking for the applause so that I can do it. Thank you very much, Oluwatoyosi, Olabande, and Tonga Augustine for this wonderful. Both of you steered this ship flawlessly, beautifully bridging the strategic policy lens of the Africa CDC with the frontline One Health passion of our student community. Thank you so much to our amazing audience also for tuning in from Nigeria, Ghana, Sierra Leone, Cameroon, Tanzania, Namibia, and across the globe. I know that this is a very busy time. So thank you for making the time to join. I hope next time we'll join early. 5 p.m. We start on the dot. Or whatever time we give, please make sure you join early. Your brilliant questions and active engagement are exactly what makes this monthly Chip Talk dialogue so vibrant and impactful. So I'm really very grateful. Remember, at Chip, our foundational rule is simple. Prevention is cheaper than cure. Let us carry the spirit of One Health and integrated action into our respective fields of endeavor this month. Please, can we just try and keep an eye on our social media and media handles, and then the communication channels for updates on our upcoming community interventions? And also the YouTube link will be shared by tomorrow, so that as many of you that want to rewatch, I would advise I will rewatch and then share the link with others so that we can see the opportunities that exist and prepare ourselves towards it. And it is said that when preparation meets opportunity, wow, you can complete the rest. So the YouTube link for this meeting of the June Chip Talk Africa will be shared tomorrow to your emails, and we advise that you watch and you also watch out for announcements for concerning our July edition. I appreciate the Happy Animal, Happy People initiative, Happy, and Vet Medics for the data support that they keep helping us with so that we can support our students. It's been wonderful because we've been having increase in the student participation. I want to encourage them because they are the future. You heard Dr. Fallah. They are the future. We need to build capacity. Young scientists, early career scientists. Like I always tell my students, there's nothing that delights me in my heart more than seeing you guys come and become greater than what we are. We have not, believe me, we have not gone anywhere. So we need you to come and pass us and do these things that Dr. Fallah is talking about. Innovation, innovation. The field is broad. There's no need for competition because there is room for everyone, every one of you, on behalf of the Community Health Enhancement Aid Project and the War Against Rabies Foundation, I just want to say thank you all for joining us again today, and have a wonderful rest of your day. Stay safe and goodbye for now. Thank you so much. I saw so many wonderful people that I was just so blessed knowing that you joined us. Thank you so much. Thank you. So do have a good night rest, and our love to your families and your friends. Thank you so much. Bye. So I'm going to stop the recording.
Thank you so much. Thank you so much, Dr. Grace. Thank you.
Bye. After I stop the recording, then we can start doing our goodbye gist for those of you that